Hi, I'm Brad Power, and this is the Cancer Patient Lab. We're pleased to have with us today Mike Troy. Mike is a caregiver for a friend who has got non-small cell lung cancer. You will see, and as you can see if you're looking at the slide that's here now, he has a very deep understanding, and he's really gone up the learning curve in order to be able to help his friend. But his friend is at a juncture, and so he requested that we review the case and give him some feedback and some ideas. This is something that we've done a number of times before. I ran 3 extended hackathons for one of the leaders that came to be the basis for the Cancer Patient Lab, which was someone named Bryce Olson, who was a prostate cancer survivor, very inspirational guy. And then he introduced me to Linnea Olson, who was a non-small cell lung cancer survivor, ALK positive. And so we ran a hackathon for her. This is a crowdsourced exercise during the pandemic that took about 2 to 3 months to help her figure out what to do next. And then also a hackathon for Casey Altman, who is a young woman with rhabdomyosarcoma, a rare sarcoma. And we've also run a hackathon for 1 or 2 individuals on our weekly webinar series like this, where it's time boxed to an hour. But it basically sets off a conversation which we can carry on asynchronously using our discussion hub, because this will be the meeting summary and notes, and the video recording will all be posted. So if people have comments, questions, or thoughts, contributions after they see the recording or the meeting summary, we'll also be looking for that feedback. So with that, I'll turn it over to Mike.
Awesome. Thank you, Brad. Yeah, so as Brad said, I am a patient advocate and work with members of the advocacy groups, the EGFR resistors, and also the Young Lung Cancer Initiative. And there's a patient case I want to share today, just get everybody's thoughts on. So just by way of background, the patient was diagnosed a couple of years ago now with stage 3B unresectable EGFR mutant non-small cell lung cancer. So EGFR being a classical oncogene driver in lung cancer and other tumor types. But the patient's next generation sequencing showed that in addition to an EGFR mutation and a couple other alterations that were kind of not really targetable, they also had a TP53 and RB1 mutation, which generally TP53 and RB1 loss is associated with a dedifferentiated state. And so generally outcomes are poor for those individuals. This patient underwent chemoradiation, which they completed on 9/21 of 2023. And soon thereafter, they were diagnosed with radiation pneumonitis, began a 6-week prednisone taper, as is sort of standard. And shortly thereafter, there was discovered on the CT that there were 2 liver lesions. And so generally liver mets, as in most other solid tumors, are considered a negative prognostic factor. Shortly afterwards, the patient began osimertinib, also known as Griso. It's the standard 3rd-generation tyrosine kinase inhibitor, so the targeted therapy that most patients go on. The average PFS, it depends on kind of what EGFR mutation you have. For L858R, it's a bit shorter, but this patient's an exon 19 deletion. Generally, the PFS is in the ballpark of 20 months. And that's kind of about what the person had here. And so they initiated osimertinib. Thereafter, one of the liver mets disappeared. The other met was reduced by probably 60%. And as you can see, it was ablated, microwave ablated. Then kind of at my suggestion, the patient pursued through the Jamie Leandro Foundation, which I know many of the viewers are familiar with. um, a neoantigen peptide vaccine. And so that was administered between March and July of this year. And while the ELISpot results were positive, they were weekly positive for about 10 of 12 antigens. Um, and unfortunately, it didn't seem to um, translate into much clinical benefit because, as you can see, um, just a month afterwards, PET scan showed mild avidity in both the right iliac and left femoral neck. It's important to note that the prior PET scan was done about, you know, almost like 2 years before at the time of the liver metastases were detected. So there wasn't really a great comparison. Um, the comparison was to the CT scans that were done 4 months before, and those the lesions were not visible on those scans. Generally, are not visible on those scans. So I think that's just a thing to note is that um, there is some data showing that while it doesn't improve outcomes, because I think most thoracic oncologists don't act on it, that actually following with a PET scan intermittently is more effective than just plain old CTs. But be that as it may, the PET scan was repeated then at the end of September, and it showed increased avidity. Um, at the time, the thoracic oncologist was like, well, we're not going to act or try to further characterize these lesions by MRI, um, and wanted to just continue to follow. And so follow-up was done, and it showed increased avidity at that point. The patient also became ctDNA positive for the first time. You can see that the tumor fraction is pretty low. It was on a Garden 360, and 0.05% is about the limit. Um, but the EGFR um, mutation was picking up at about 0.3%, so showing some degree of pretty heavy degree of amplification. And then again on 11/1/2025, a second liquid biopsy was performed. Once again, it was positive, slightly higher variant allele fraction for EGFR, but not too much. So I think that speaks to probably the degree of proliferation, at least to the extent it's showing up in ctDNA. And so a third site was noted on a second read that was performed at Johns Hopkins. And so they're basically in some three bone lesions, all about a centimeter or less, um, and that apparently are resistant to the tyrosine kinase inhibitor. So I guess where things stand currently is the patient is scheduled for mapping for SBRT. So the idea is basically to radiate radioablation of all three sites. Um, Prior to that, we're going to push for a bone biopsy. That's supposed to be performed next Tuesday. I've been working with this patient to try to get, and this is a little bit crazy, but I don't know if anybody has anything on this, and we're trying to get an organoid made because the tissue yield from this bone biopsy is probably going to be so low that it's unlikely that any sort of advanced sequencing could be performed. I think Boston gene, the limitation in terms of the tumor yield that they need in order to perform whole exome transcriptomic sequencing is about 250 milligrams. So like 2.5 milligrams of tumor tissue, which I think if they do a few passes is probably about what you would get. Although I think a lot of it might be lost in the decalcification process. but basically the idea is there any way that this patient can escalate therapy, systemic therapy, in order to prevent um, further progression of the disease? The two things that I'm mainly thinking about are there are a number of antibody drug conjugates that have recently been approved, and Dr. Pasiani has shown, at least in preclinical models, that initiating basically a combination of the targeted therapy and one of these TROP2 directed antibody drug conjugates was able to delay the emergence, or I guess reemergence, of resistance. And so I think that is a thought, although antibody drug conjugates with the current payloads uh, currently work much better with rapidly proliferating cells. So you might be able to wipe out the rapidly proliferating resistant clones, but there's a question about whether you hit any of the drug tolerant persisters and shrink that population further. And then there's also the the consideration about whether there are any further immunological approaches that could be kind of leveraged as an orthogonal tool to try to um, delay further progression of the disease. Now, classically, checkpoint inhibitors, which have shown a lot of promise in other solid tumor types, are not indicated here. And in fact, when combined with tyrosine kinase inhibitors, they have been demonstrated to show a lot of toxicities, particularly interstitial lung disease, serious interstitial lung disease. So that's generally avoided. But I think there are other options. In fact, I've contacted Immunity Bio, which others might be familiar with. They have an IL-15 agonist, Anktiva, which I think increases uh, T cell proliferation, but it's like raises your lymphocyte count by about 200%, and I think leads to like a natural killer cell expansion of 800% on average. And I know it's being used in bladder cancer, I believe. Um, so the idea is like, well, could you? They've already kind of this patient's already pursued the vaccine, like a peptide vaccine. Could you combine the administration, basically co-administer a a peptide vaccine, which again, there's the questions of are those antigens even presented? Are they immunogenic? The patient can't perform mass spec, at least won't be able to unless they get an organoid on the bone biopsy because the yield is going to be so low. But I guess the question would be like, if you could get your hands on this IL-15 agonist, could you combine it with a vaccine and therefore amplify the effect? Um, and sort of you get almost a in vivo sort of effect that you might get with like a cellular therapy. So anyway, those are kind of the questions for discussion, and I don't know whether anybody has any other thoughts. I know there are sort of smaller um, interventions, like things that I've been thinking of with thymosin, um, one alpha one, I guess, um, as just like a because the patient's lymphocytes are kind of low, and generally patients with higher lymphocyte counts do better on targeted therapy. Um, and there, you know, the other consideration is that chemotherapy has been shown in this a recently published trial called the Compel trial, that basically at the time of failure on the osimertinib, the combination with chemotherapy. Granted, it was indefinite chemotherapy, which I think is one of the key things that the patient would like to avoid. And quite frankly, I'm in the boat with them that, I don't think long-term use of either chemotherapy or an antibody drug conjugate is a good idea. But those are kind of
Um, Mike, in general, we use the raise hand feature, which David is doing, and I'll call on, so I'll moderate this part. And then also people can submit comments or questions through the chat feature. Let me just do two stage setting things though before I call on David. First of
Sure.
all, talk about geography. You mentioned Johns Hopkins, and so where is your friend being treated, and what is their willingness to travel?
Yeah, sure. So the patient's located in Boston, being treated at Dana-Farber Cancer Institute. I think they're pretty much willing to go wherever. Um, you know,
And
it's
I mention that because I'll call on Roger, but there's a thing called dendritic cell expansion, which is something that people have traveled to Japan for. We had a webinar on that, and so that's just like obviously above and beyond that not everybody can afford to do, but that's just something. That's why the geographic scope, and also when you look at clinical trials, sometimes willingness to travel is a feature.
yeah,
And then the
yeah.
other thing is, just quickly, Mike, you're obviously very sophisticated on this, and I'm looking at Russ, and who I know uses a lot of AI and whatever. How have you educated yourself? Just because we believe at the Cancer Patient Lab that engaged patients and caregivers get better outcomes, but obviously you've come up the learning curve. You're very sophisticated. You could be teaching a PhD course, I think, in at least in this case.
Mhm.
What, how have you managed to educate yourself and get up the learning curve? Typically, people use AI, peers, and experts. Can you just describe that story, part of the story too?
Yeah, I think basically um ever since I got involved, I kind of first joined social media and started following a lot of the experts on like Twitter or X. Um, and basically, I think by kind of reading the articles that they shared to the extent that they were publicly available, um, at first I was consulting sort of like secondary sources like OncLive or something with just like sort of standard industry updates and just familiarized myself with like the standard of care, what the outcomes were, started following the trials in the space, and read a smattering of kind of preclinical papers. And from there, I think it was starting to attend conferences, kind of became aware of the issue of drug tolerant persister cells and like these, in a therapy where you do have targeted or a field which you kind of rely on targeted therapies. There's obviously this population, there's this reservoir of cells that are not sensitive to the targeted therapy, which end up sort of giving rise to the resistant clones and ultimately leading to disease progression and death. And so, just kind of fixating on that problem and then also looking to the other solid tumors and seeing sort of the successes that you had with melanoma, with and obviously in the hematological space with sort of these immunotherapies, and the fact that that really seems like the only way to drive these durable, lasting responses, even cures. And so I think the idea was like, how do you bring those into an immunologically cold tumor? And obviously, um, at the NCI, Dr. Rosenberg has done a lot of work in there. So I just kind of read about that. And I mean, I've been going to conferences. I just came back from SITSI. So I think I kind of got on the AI train a little bit later, I'd say, than most. At first, it was just mostly reading publications and, like I said, following the clinicians themselves and kind of seeing what they were discussing. And I think from there, I was kind of able to get enough familiarity that I could um, I could engage in like kind of an intelligent way with patients and sort of clinicians.
And what has your experience been in bringing the insights to your friends' doctors? Are they receptive? Has that been a good conversation?
Um, Generally, I think it varies. I don't think so. I don't think clinicians really like um advocates or sort of having patients who are highly informed. It, in my I think especially if you're kind of pushing the boundaries of kind of what standard of care is. And, I mean, when you look at the curves, a lot of people have the reaction like, this is just, I'm not gonna, as a friend of mine says, I'm not gonna get on this curve. I can't. And I think that like inevitably leads to a battle because I think physicians want to be evidence-based and are kind of, although there are some alignments of interest, that they don't have the same as the patients. I mean, I think quite frankly, the way in which they're balancing risks are totally skewed. And if you're a patient and you're looking at, well, if you combine these two therapies, there's a X% chance of getting a high grade adverse event. And then, for the oncologist with, medical malpractice or whatever it may be on the line, that is an overwhelmingly important concern. Whereas if you're a patient and you look and you see, well, the the sort of risk benefit ratio I'm weighing basically certain death on the other side, well, it becomes a lot more appealing to sort of go off the beaten path.
Let me just ask one last question. I'll turn it over to David. Building on that, um, you are caregiver to your friend, and so you might come up with, I think you should try this two drug combination or something, and
Hmm.
or get a second opinion. And often
Hmm.
they might say, I don't want to upset or offend my trusted doctor or medical team. And so you actually have a like almost like a twofold challenge. You have to first persuade the patient that this issue should be raised before you even then have to deal with the medical team and their concerns, which you just shared. How has it been working with your patient that you're providing advice to in convincing them that the research that you're doing are things that they would want to push forward?
Yeah, I think generally patients are very receptive. There are a number of Facebook groups where patients kind of share experiences, and I think it's pretty easy to get a patient to engage, particularly when their experiences they go in to see their oncologist, and it's pretty clear that the oncologist, understandably is dealing with, possibly hundreds of other patients and are just looking down and looking at your case, once every 4 months. I think there's just limitations to kind of what they can do. And I think one thing that you can do, and I've recommended in this situation, is there are a number of expert physicians that you can seek out. In particular, I'd highlight, at least in the oncogene-driven lung space, um, Vincent Lamb at Johns Hopkins has been, I think he's a tremendous thoracic oncologist. And although, I don't think he's a younger doctor and not given sort of, um, doesn't sort of have the reputation that some others do. I think he's much more open to these, at least having an orthogonal immunotherapy approach. He's the person who told me about the Jamie Leandro Foundation and sort of basically using a vaccine in this setting. And in fact, that's kind of where his work is. And then John Haymack at MD Anderson, who's head of thoracic oncology at MD Anderson. Um, but with all due respect to um, some of the other uh, great thoracic oncs out there, like Ross Camage, who I know um, has helped a lot of people in the cancer patient lab. I think he's the best because he's simply the most aggressive and the most willing to try sort of out of the box combinations. Ross Camage is also excellent, and I think basically through talking to people like Dr. Camage, I know um, he has incorporated ctDNA and is kind of a leader in that he follows liquid biopsies, and then if you've seen uptick in ctDNA, I think he increases the frequency of the scans with the idea that you could then ablate um, any sort of distant metastases as they arise, and therefore keep people on targeted therapy for much longer. So I think it's learning from um, if you learn from the practitioners and the people who are kind of the best at it, and then you try to implement it in your own and advise patients about it. And I think if you kind of know what you're talking about, patients listen.
Just I'm one. I keep saying one last thing, but one last thing. Um, how is it that you approach someone like Ross Kamich, who is recognized? He was active in the Linnea Olson hackathon. How do you approach someone like that, get their time? Are you going through the formal process of getting a second opinion, working with your patient, or are you doing this through other means?
Um, so sometimes I've met with various thoracic oncologists through getting like a second opinion, but Dr. Kamich, I just met him at a conference once. But the other thing is you learn from the patients themselves. I think some of these Facebook groups have been very enlightening in terms of you just hear about how others are practicing. And I think you just take that in and kind of
Yeah, so it's like
try to
second, you're getting the conversations they've had with those experts, and then you're just incorporating that because
exactly,
they're asking the same questions that you have, and you get their answers to those questions. It's as if you talk to that source. Okay.
exactly.
Now, David, I'm sorry for the delay.
Not a problem. My question is just one for clarity in the plan going forward. I see SBRT and then bone biopsy on your list there. What's the timing on the SBRT? I'm assuming the actual ablation will be after the biopsy, but is there
Exactly.
already a tentative plan for the number of sessions, the number of grays, that sort of thing?
Yeah, can't tell you how many grays, but I think it's going to be done in 8 fractions. I think 5 to the right iliac and left femoral neck, those 2 sites, and then there's maybe 3 to that remaining um, right mid femur suspected metastasis. Um, so yeah, so basically it's I think going to go forward in December is the tentative plan.
And
Um,
then some sort of follow-up imaging sometime
yeah,
after
so
that?
yeah, so as of now, the the pet is actually it's gonna have to fix this on scheduling. I think it's scheduled for like December 9th. So I think the idea will be push that off until after we've completed SBRT, and then um I think more than anything though, following with serial monitoring with liquid biopsies, and in particular, I am interested in integrating the haystack liquid biopsy. I think it was just recently acquired by um
Quest, they were just on a few weeks ago.
yes, yeah, exactly. So I think a tumor-informed assay, although the patient sample that would be used for the sort of whole exome sequencing to inform it would be probably like 2 years old, so it's probably not going to be as sensitive. Um, but I do think that that's probably the best way to go forward as opposed to one of these agnostic like Garden 360 liquid biopsy assays.
Thanks. That we've had a number of sessions on liquid biopsies, and we'll include those in the notes so that people can. Mike's glossing over a lot of things that people probably don't know all the definitions to, and I know I don't. But for example, those sites you mentioned a couple of anatomical terms that I don't recognize. Femur, I know that's a leg
Yeah.
bone, but what were the other two? Are iliac and something of
Yeah,
those
so
parts of the body?
basically top of the right hip bone,
Oh,
um, and the left top of the femur, and then midway down the right femur are like the three sites that have shown increased avidity, which is pretty low. Um, it's like 4 or 5-ish, and you know, um, ctDNA is kind of at the lower threshold of detection, but it's um not it's not the problem is with in these oncogene driven lung cancers is kind of like if you get resistant disease, it's kind of downhill from there. Kind of so I guess the question really is like, is there a way to put it back in the box?
Okay,
Um,
got it. Maybe Calmudi and Ricardo have thoughts on that. Calmudi, you're up next. You have,
Yes. Hi, Brad, and hi, everyone. I've been listening, and yeah, hi, Mike. I have some questions.
mhm,
So I see that the bone biopsy is scheduled for this coming Tuesday, which is it's timely that we're having this call. And I can think of three companies that you should definitely contact immediately. One being Travera, the other
Funny,
being
I called them yesterday.
okay, excellent. The other being Sage Medic for the Sage Oncotest. And the
Chris
third,
Apple, I believe you've also been in touch
Chris,
with Mike.
okay. And then the third one being genomic expression for RNA expression, uh, looking at RNA transcriptomics. And I believe all three of these need, well, I know that two of them need fresh sample, and then the third, I don't know how genomic expression actually collects their samples, but Gitte is, I see that her note taker at least is on this meeting. So
Okay.
all three companies are, you should absolutely be in conversation with them, which I'm hearing that you are, which is excellent. And coming up with a list of the kind of the ADCs or any kind of agents that you want to test against these tumor cells. Travera,
Hmm.
in my knowledge at least, uses the least amount of cells.
Right.
They need the least amount of cells, so that could be something. And then if you just come up with a list of the agents you want to test with Travera, we can do this maybe on this call, or if you already have a list, that's uh, the topmost priority in my mind, listening
Okay.
to everything you've said.
Yeah, I contacted Trevera
Mhm.
because I know one of their scientific advisors is kind of like the head of Dana-Farber's patient-derived organoid
Uh-huh.
section. And so I contacted him directly, but also uh, assuming that he's not going to help because, quite frankly, I'll just state it straight out there. I've not found anybody at Dana-Farber, Brigham and Women's, or the Broad Institute,
Uh-huh.
with the exception of actually somebody who I didn't mention in the overview is Ricardo, who I think has taught me more than anybody else, and as somebody who I basically just tried to follow in the footsteps of. Um, but there's basically nobody who's in Boston has been in any way helpful. Um, and so I just saw that their company, I didn't know whether or not they actually help patients make it's but
They do.
Oh
without
no, actually, Travera is not even making organoids. It's an immediate test, just working off of the cells that are isolated. So
Mhm.
Dennis Watson is the person you want to contact. I have his email address, and Brad, I know Brad is also
Yeah.
knows Dennis. So he's extremely responsive, and he will really help you. He'll even hop onto a call with you to kind of sort these things out. You know, what you need to send them, when you need to send it, and even in making the list of agents you would like to test. But since there's time is of essence, so I would say just today, if you can,
Yeah.
as soon as, yeah.
Awesome.
Okay.
Yeah, we've had two webinars with Travera, and Dennis Watson is very generous in supporting patients.
Awesome. Thank you.
Thank you,
No,
Calmodi.
Mhm.
Ricardo?
Yeah, thanks for the kind words, Mike. Great seeing you. If- is the only place that could do the biopsy was the bone? There was no other met that was able, or just two sensitive locations?
yeah, it was just all three sites are bone sites, so um
Oh, I
I
see.
guess it's just yeah.
Well, listen, from the guy that has been radiated 8 times, and 2 of them have been on bone lesions. What HAMAC educated me on was like these bone C sites have their own they're their own system versus the visceral places. So initially I was very concerned about them, like, and particularly like my state, like my ability to, its impact on just the bone marrow, etc. But we navigated through them and we were fine. And so, once again, I'm not providing medical, advice, but it wasn't the end of the world. And we've done a lot of them. Most recently, my L5 2 months ago. Uh, Anything else that you found through all the going through SITC from an immunotherapy perspective, or something that is kind of in the trial format, that where the hope is and the future is that that you could pursue? Like, I do
Hmm.
talk to some of the same people around cell therapy, and do you have a target that you've like already identified, or a sequence for a TCR, for example, or something like that?
Yeah, yeah. Thanks so much, Ricardo. Yeah, once Brad, going back to your question, in terms of how I educated myself, I basically early on um talked to Dr. Lamb. I got in touch with Alexander Rubin at MD Anderson, who works in the cell therapy space, who put me in touch with Ricardo, and basically, in addition to outside reading, everybody who I kind of met who was plugged in was all through Ricardo Salgado. So like basically he was the one who like I just saw what he was doing and just tried to copy and learn from it. So I think he's the problem is it's kind of a one of one type person, and it's kind of hard to replicate. But obviously, if anybody in the future has questions, I'm happy to answer them. But Ricardo, to your point, so basically, one thing that I've become increasingly interested in, well, two things is that I think there's some issues with obviously cell therapy and solid tumors. I think there's something going on with the ex vivo expansion that is making them so ineffective at infiltrating the TME. One thing Carl June was talking about at SITC was that they're trying to combine them now with oncolytic viruses, basically in order to help increase their ability to traffic into the tumors themselves. Um, and I guess with the oncolytic virus, trying to like heat that up. And there's a few companies. I think there's Imugene has one that I think we've talked about, where they have a vaccinia virus. I think they administer it systemically, although I'm not sure. And then they're either using, I guess it has a transgene that gets the tumor cells to express CD19, and then I think they're following it up serially with a bispecific T cell engager targeting CD19. Um, but yeah, so in terms of there is one target, it's a TAF1L, which I guess is a cancer testis antigen. Now, it might, there's no confirmed TCR that I know of for my mom's HLAs in terms of something that's immunogenic and won't have cross reactivity, because I guess TAF1 is this transcription factor that's, ubiquitously expressed. And so there could be a problem with cross reactivity there. But in terms of cell therapy that might work, I think TIL has obviously shown the ability to, in certain sort of more reactive tumors, to people get responses like melanoma. I think one thing is, rather than bulk TIL, I think you kind of have to, like what the NCI does, where they split the TIL into like however many various little separate cohorts, if you will, and then test reactivity against the tumor. I don't think Obsidian Therapeutics does that, but I know that their TIL, they can sort of selectively expand it with this prodrug for IL-15. And so they're working on basically a formula where um, you don't have to lymphodeplete nearly as much, because that's the other thing is, obviously, as you know, when you go into the cell therapy realm, you kind of take a big shot in terms of your own lymphocyte count, because you have to lymphodeplete, and then it's kind of anybody's guess as to whether or not, especially in these more immunologically cold tumors, you could even see a response. But yeah, that's basically the things I'm thinking about are um, there's somebody at the University of uh, Pittsburgh, forget the guy's name. He just ran a trial in uveal melanoma. So the TMB there on average in the trial was 0.7. So super low TMB, immunologically cold tumor. They see there's some TIL in the TME, but they're kind of just in this dormant state. And apparently he has some genomic assay that he's running in which it's predicting whether or not you have reactive TIL or basically non-reactive TIL. And he was able to get a response rate in terms of like if you were positive on this genome-wide association, the chance that you get a response was like 50%. So that's pretty good. I also talked with this guy, Frank Lowry at the NCI, who's come up with another sort of test to determine reactivity of the TIL so that you don't have to like culture each batch individually and see whether or not it's reactive. Um, so basically, those are the two things. I think, yeah, that's kind of like the only thing that I've been thinking of. I know that Dr. Rezvani's group is working on a TROP2 targeted CAR-NK, and that TROP2 is a big target in both small cell and oncogene-driven lung cancers. It's usually highly overexpressed. Pasiani's group is looking at targeting it with CAR T, but this TROP2 CAR NK is already in clinic. But I think the issue is, once again, they're not seeing the um, persistence is a big problem. I think they've amended the protocol now so that they're infusing it 4 times, but to undergo lymphodepletion 4 times is insane, in my opinion. And the other thing is, I just don't think they're getting great infiltration and sort of activity in the tumors themselves. So uh, a lot less toxic, which is a great thing with CAR NK, but issues with persistence, and then again, um, just in terms of the ability to actually eradicate some of these tumors, it doesn't seem that great.
Ricardo, I know some of your story from the past, and one of the things that you are a leader in is getting very intense monitoring as you're being treated so that you can tell very early whether a treatment's working or not, if you're having side effects, to deal with those immediately. Is there anything that you would recommend along those lines?
I mean, I think he's on top of it. We talked about, all these tumor-informed liquid biopsies, which is the best way to really, I mean, so far out there. I think, are you using a Signatera or Personalis?
Not yet. We kind of had this silly idea that if we might need, we didn't know how much, we didn't have a whole lot of tissue, and
Well,
quite frankly, I think,
these are blood-based tests, Mike.
yeah, but I guess in order to perform the whole exome
Ah,
sequencing, in order to make that the tumor informed assay, and I think what the other difficulty that we had was just simply a lot of uh, oncologists are just not willing to
Yeah.
order. They have whatever test that they order, and they say, "Hey,
So,
we have a workflow for
so
that. We don't do."
the ctDNA that you presented earlier was based on without tissue, so naive
Exactly.
Okay, I see, I see. So it's not really
Yeah.
as got it. Okay.
Yeah.
I mean, listen, the challenge with a bone biopsy, and that's the same reason HAMAC didn't get one for me when we were radiating the bone lesions, was the ability to really get tissue that is measurable and you can do something from it is very difficult.
Mhm.
Um, so we didn't do it. But it doesn't mean you shouldn't do it. You should look at the probabilities and go out there and do it. But going back to your question, Brad, like Natera has been very important, to me, and they've been like a great predictor, unfortunately, of many things. But it helps me. It at one point did help me adjust literally not week by week, but like bi-weekly to bi-monthly, kind of changing and adjusting and increasing and moving around some of like my real-time strategy around immunotherapy, chemotherapy, and targeted therapy at the same time. So, yeah, I mean, but Mike's definitely encourage him to continue to do that. And I thought that they had it, so I was just going to suggest this: make sure you refresh it. That's it.
Mhm. Mhm.
Yeah. I'll just mention that I work with Tony Magliacco of Protein Biodiagnostics, who's a concierge expert in testing. And for me, I got the Natera and it was called Liquid Trace, where it's again a blood biopsy where they can do it's like 300 or 400 DNA and about 300 or 400 RNA. And also, just you had mentioned TROP2, and the only place I've heard that before is that somebody identified it through an RNA-seq. It didn't show up on a DNA-seq, but it did on RNA. And so getting RNA testing, which Cal Moody recommended, I think as well. I don't know if your patient has gotten RNA sequencing, but that can also give more information.
Yeah, thank you. Yeah, so I think um there was whole exome and whole transcriptome sequencing performed by Boston Gene on the liver metastasis. So that was, what I 73 TPM, and TROP2 is also pretty highly upregulated. The problem is like the for those antibody drug conjugates, that has to be those proteins have to be expressed on the cell surface. And so generally, you look at these cell stains like IHC or FISH in order to assess um, whether or not there's sufficient expression to use one of these ADCs, or in the future, like a cell therapy, um, or sort of a T cell engager, to the extent that that's ever becomes a thing with either of these targets. But so that is kind of why we're going after the tissue. Um, but again, the whole issue being that there probably will not be sufficient tissue, um, short of culturing up an organoid, which already I think will be very difficult to do, because I think basically that the average yield, I think you need a yield of like 30 to 50 milligrams for like establishing an organoid. And I think we're talking about something like uh, probably like 3 milligrams of tumor tissue is the likely yield. And so it could prove very challenging.
Got it. Alexander Lalov, you've been very patient. Sorry I haven't called on you sooner.
I just wanted to add about the Sage Medic. Uh, I work with Dr. Chris Apfel, and you need to contact them if you decide way ahead before the biopsy, because they have to ship a nano-cool box which needs to be on site, that the tissue can be transferred from the biopsy straight in this nano cool box for overnight delivery.
Sorry, what company is this?
Sage Medic,
Sage. Okay.
Sage Medic, Dr. Chris Sapfel
Okay.
had.
Yeah.
Okay.
Yeah, and we have horror stories of getting pathology departments to ship things outside. So you have to like check, double check, and triple check, and then you can still have trouble. So it can be hard. Um, let's see. You mentioned microwave radiation for one of the treatments that your friend got. Is that the same as histotripsy, which I've heard about, or is that something else?
So I think histotripsy is kind of like almost like similar to an ultrasound. I think
Yes.
it's, but whereas radio microwave ablation is just like an ablation technique similar to thermal ablation or cryoablation. So basically, you use a probe, you insert it into the site, and the local control with microwave ablation, I think, is pretty high, a little bit less than SBRT, but around that. Um, so anyway, the for whatever reason, the radiation team was unwilling to locally consolidate the liver metastasis, and so I'd seen the North Star data out of or MD Anderson, the actually Bright Star data at the time, and it was an out basically showing that local consolidative therapy improves outcomes on, quite frankly, any effective systemic therapy. Um, Although this was for targeted therapy. And so I just extrapolated from that, said, well, that will work in EGFR mutant tumors if it works in ALK. And so from there, I was able to get the ablation team to come in and microablate the study.
Okay. Russ Hollier had some questions on ctDNA. We may have covered it. Russ, is there anything, you mentioned a number of questions in the chat.
Let's see. I think you talked about Natera a bit. My audio's been coming in and going out. What type of ctDNA testing are you doing?
So I think that's one of the shortcomings is it's only been agnostic. So it's not tumor informed. It's been Guardant 360, so the sensitivity is not nearly as high as with Signatera or like a tumor-informed assay. Um, Quite frankly, part of that is we've had difficulty getting the thoracic oncologist to actually, order because you have to do whole exome sequencing for any of those things, and generally you need like a doctor to sign off on it. Um, we've kind of been at this impasse where we had uh, the tumor tissue from the biopsy had pretty low tumor content. And so it was difficulty to get Boston Gene to perform the whole exome sequencing. And so there was a question of whether we would burn up the remainder of the tissue, just sending it out, and whether or not there could be another use for it. So we were just monitoring with a tumor agnostic assay, but obviously that's not nearly as sensitive and not as good. That was kind of what we fall back on.
Okay, so you don't use Natera so much. You've had problems getting that prescribed for you or scripted?
Yeah, and I think just in terms of like a lesson, I think this is one of these things where it's like, sometimes you feel like you need to pick your battles, but it's really worth having the battle because if you don't, then you can,
I
you know,
I find Natera MRD extremely useful. I also do the Garden 360 and the tumor agnostic one, and I've had maybe 6 done in the past few years, and I have never gotten any results from it. It's pretty much negative every time. Now my TMB is actually measurable, supposedly, but that's it. My tumor fraction is always my VF is always less than 0.05%. The MRD, on the other hand, has gone up positive and fairly large, 1.16 mutant tumor molecules per milliliter of blood. It's gone up, it has predicted my Mets far before PSMA PET scans, and Garden didn't even predict him, not even close, and PSA didn't predict him either. I have prostate cancer. So I would, if there's any way you can get that done, I would suggest at least looking into it, considering the MRD testing from Natera or some there's a couple companies that do it.
Yeah, agreed.
Have you considered this is a not standard of care, and it's something I'm experimenting with, and I've seen some positive results, but I'm not done experimenting. I can't conclude for myself even, and certainly not for others. Have you considered metronomic CPD? Cyclophosphamide. It's a type of chemo. Metronomic low dose, very low dose. And that
No.
is ALC. Okay, that increases ALC in natural killer cells. And what I have seen in myself is if I use it, my ALC and NK increases substantially after about 2 weeks, and then drops down to baseline after about 4 weeks. So I want to see if that's repeatable, if I can pulse it for 2 weeks on, and then go off at 2 weeks and go back on 2 weeks, and see if I can repeat. I've done that twice. I've done 2 cycles. That's not enough data point. I'm just wondering if you've looked into that, thought about that, because you were
I mean,
mentioning NK cells.
so I've not looked into that per se, but to your point, I guess the idea with um like chemo IO, which is like standard and everything, to your point, like the idea is that chemo might have some sort of it helps with sort of immunogenic cell death and therefore might have like an immune stimulatory effect. Um, Kind of like a related point, but so basically antibody drug conjugates, which is like basically targeted chemo, um, it's been demonstrated lung cancer and I think other tumor types is you're even in the resistant disease setting with patients with high tumor burdens, you're getting these waterfall plots showing massive reductions in tumor burden, like 70, 80%. And I think the question is if you're at an MRD setting, to kind of exactly what you're doing, can you bring those therapies forward and in an intermittent fashion administer a few cycles, and can you eliminate both the rapidly proliferating cells, but also can you hit some of those tolerant persister cells that, the standard therapy, whatever systemic therapy people are on, they have upregulated expression and maybe they're not internalizing it at the same rate that a rapidly proliferating cell would be, but they internalize it, they eat the chemo and basically are killed. I think that is kind of something that I'm curious about because there are a few approved therapies. I think most thoracic oncologists are not going to reach for them until you have full-blown resistant disease, which in this patient's case, that the thoracic oncologist said that they wouldn't consider chemotherapy until they had more quote unquote frank progression. Now, I think everybody on this call will tell you nobody wants to wait until you have frank progression to try to get on top of it. I mean, that's a pretty crappy plan if that's your plan. And
Yeah.
so the idea basically being, yeah, can you bring some of these ADCs to this like MRD state? And I think one of the issues is like unless you have IHC staining, this is not true for Dato-DXd, which is AstraZeneca's TROP2 directed ADC, where it doesn't appear to have like a great relationship with like TROP2 expression, but at least there's a ADC targeting MET. The name escapes me at the moment. But basically the idea being that it's shown that this patient has fairly high, at least by RNA-seq, um, transcriptomic expression of MET. And I guess the question is like if on either the old tumor or on the new tumor, you could show that they have uh, MET amplification. I think it has to be like 3+ on at least 25% of the cells in order for this therapy to be that was the only indication it was approved for by the FDA. But the idea being like, can you bring it forward to this setting, this MRD setting, and can you drive a deep response that would allow you to remain on the targeted therapy for a longer period? So
Yeah,
that's definitely what I'm thinking about.
Good, makes sense. One other question. Well, I like metronomic CPD. It's very low side effects. In fact, I haven't noticed any side effects at all. Another question I had, you mentioned thymosin alpha. Have you, as your friend, used it?
So no, basically the reason why I was thinking about that is, we went through the whole vaccine thing, and the ELISpot results are pretty weak. And I think, especially in these immunologically cold tumor types, in order to drive an anti-tumor response, like obviously you need like a reactive antigen that you have a TCR against. But the other thing is, I think in order to get the T cells to traffic there needs to be some sort of combinatorial strategy. So either a cytokine, or like here you have like a peptide, and the idea is like maybe those two things combined might have more of a immunogenic effect. Like you might be actually able to drive it. Um, to your point though, in terms of cyclophosphamide and all these things, I've met with Greg Lizet at MD Anderson, who's like he ran an EGFR vaccine trial in China, and he thinks like the targeted therapies themselves also create this immunogenic cell death that in combination with the vaccine, even in the resistant setting, they're able to show some extended progress-free survival, etc. So I guess that is kind of the idea with maybe thymycin alpha-1, even in absence of a vaccine, when combined with a targeted therapy, if you've increased lymphocytes, maybe you get more of a response. I don't know, but it's something that we're thinking about.
Yeah, that's kind of what I'm thinking about too, along the same lines. I'm planning on trying thymosin alpha as soon as I can, get it. I tried it about 7 years ago or 6.5 years ago, and I demonstrated. I only did one test, so I can't say this with certainty. But I had maybe a 3x increase in white blood cells, a massive increase. ANC increase, NK cells increase, everything, just a massive increase. And then I had a test about a month later. I was still using thymosin alpha, and I could be wrong about the timing. It was so long ago. But my white blood cells and all my different components dropped down to my baseline pretty much. So I gave up thymosin alpha, but it might have kind of the same effect. It might boost the cells through first it wipes out the sickly ones and then regenerates some cells. So it might increase those responses, and might increase those cells for a certain period of time and then drop down. So maybe you have to cycle it, like I found with metronomic CPD. If I want a response, it seems like I have to cycle it.
Mm-hmm. Yeah,
Uh,
yeah, very interesting.
I'm conscious of the time. Kalmudi, you had your hand raised, and then we should probably wrap.
Yeah, yeah, hi. I just wanted to confirm that it's non-squamous NSCLC, is that right?
Correct.
Okay, so I sent a meta-analysis of various combinations that have been tried in various clinical studies over the years, and I've sent the link in the chat. Just wanted to highlight that. And then you mentioned MET amplification.
Mm-hmm.
So I'm going to send another relevant article that you can kind of look at. But once again, I just wanted to highlight contacting Travera immediately and getting hold of them. Same with Sage, the Sage Oncotest as well, because like was mentioned earlier in the call, there's some logistics involved there. They have to send people to get the fresh tissue. And if you are not able to get the fresh tissue to both these companies, then the opportunity is lost. So
Yeah.
once again, Dennis Watson, I shared his email address in the chat. So just definitely be sure to reach out to him. He responds immediately. So yeah.
Okay. Excellent. Thank you so much.
Thank you, Kamudi. Mike, I always like to let the discussion leader have the final word. Is there any parting words of wisdom or any closing comments you'd like to make?
Not really. I think for other people who encounter this later, I think that the big thing I would say is, especially if you are in the space where there's a targeted therapy, I think trying to get out in front of it and develop your sort of strategies as to like, okay, upon progression, I'll look here for like 1, 2, 3 kind of and always to look as people on this call have kind of highlighted is I think like standard of care approaches, they're nice to have, but you really have to think outside the box if because it's just advanced solid tumors, they're just tough to deal with. Like so